My dear students, welcome. You are on a session on anti-diabetic drugs, and on a previous session we have discussed insulin, we have discussed the various insulin preparations. At the beginning of the sessions, I would say it again for you about the insulin preparations briefly and then progress with this session. The insulin preparations which are available on the basis of the onset of action and the duration of action, you can see the table. Ultra rapid acting or ultra short acting insulins, that's insulin Lispro, Aspart and Glulicin. They are given at the start of the meal for the postprandial effect to control the postprandial hyperglycemia, and they begin their action in 15 minutes and the action gets over by 3 hours. The speciality of these ultra rapid or ultra short acting insulins or Lispro, Aspart and Glulicin is they are not suitable to be given in pregnancy. So please remember, ultra rapid, ultra short acting insulins are not used in pregnancy. We go to the next row, the rapid acting insulins which are used subcutaneously. There is semi-lente insulin, that's another name for rapid acting insulin. This is regular or crystalline zinc insulin, and the action begins in 30 minutes and the action lasts for 6 to 7 hours. What's the speciality? What's special about this rapid acting or regular insulin? It's useful in emergency situations. Is the insulin which is the drug of choice in emergency situations. In emergencies, it can be used by intravenous route of administration, and this regular insulin is safe in pregnancy. So if it's pregnancy associated diabetes mellitus, always go for regular insulin. It is injected 15 to 30 minutes before meal as indicated here. The next insulin is intermediate acting insulin. Onset about 8 hours and the duration about 20 hours is also called as lente insulin. And the example is NPH insulin, that's neutral protamine hegdon insulin, and it's or there is also insulin zinc suspension. There's a long action here, and this is given always by subcutaneous route, and it's combined with short acting insulins. The next group is long acting insulins. The action lasts for a little longer period of time, begins by 8 hours and lasts for 22 to 24 hours, and this long acting insulin is also called ultra lente insulin. The example is protamine zinc insulin or PZI. Again, it's got long action and always used by subcutaneous route of administration, and it's often combined with short acting insulin. The last group, which is shown on this table, is ultra long acting insulin, which acts for up to 24 hours, and you have glargine insulin and detimir insulin. The speciality of these insulins is they are called single peak insulin because there is no fluctuation in the level, and the action is sustained. As you can see, it's written here, there are prolonged flat levels. The dose response curve is not a steep curve, it's a very flat curve, very smooth curve, and it's prolonged flat curve. So it's sometimes called peakless insulin or single peak insulin. The importance of these insulins is their pH is 4. So you cannot mix these insulins inadvertently with other insulins because there could be incompatibility as far as the pH is concerned. So important to remember, ultra long acting insulins, their pH is 4. Don't mix them with other insulins. And there is a risk that there could be nighttime hypoglycemia. Nighttime hypoglycemia has been noted with the ultra long acting insulin. So this is a nice table which made you to rush through the various types of insulin. Let's go to the next slide. Combinations of insulin preparations. How do we combine? Usually one preparation in the combination is rapidly acting insulin, that's semi-lente insulin, and the second one is ultra lente insulin, that's a long acting insulin, and they are combined in the ratio of 30:70. So semi-lente insulin, the usual standard dose or rough standard dose would be 0.5 to 0.8 units per kg body weight, plus the ultra lente will be 0.2 to 1.6 unit per kg body weight. So we combine one rapidly acting insulin, one long acting insulin, because rapidly acting insulin will take care that the action begins fast, but its action is going to get over after a certain period of time. By that time, the ultra long acting or the long acting insulin, ultra lente insulin or the long acting insulin is going to take over the action, and is going to carry the action forward. You have to split these doses, whatever I said, into 2 doses, and they are given as 1 dose before breakfast and 1 dose before dinner by subcutaneous route of administration. In other case, you can also combine a semi-lente or rapidly acting insulin with a lente insulin, which is intermediate acting insulin. So a rapid acting insulin can be combined with lente insulin. Example of lente is NPH, neutral protamine Hegdan insulin. So these are the combinations. Let's have a view at the various insulin delivery systems. Insulin can be given subcutaneously, as we are discussing right now, by conventional disposable needle-and syringe. There are portable pen size injectors available. Continuous subcutaneous insulin infusion devices are available. There are also programmable pumps which deliver a constant level of insulin for a period of 24 hours with a basal rate. And the newer things include inhaled insulin, which has got the characteristics of a rapid or short acting insulin and is useful for mealtime hyperglycemia. That's a postprandial hyperglycemia. 1 milligram of the inhaled insulin, the effect is equivalent to 2 to 3 units of subcutaneous insulin. This is something new, that's the inhaled insulin. Lastly, buccal spray of insulin has come to the market, and there are constant efforts to develop the oral insulin. I take you to the next slide, and you can see the insulin pen injector here, and this is the insulin jet injector. The first one is pen injector and the second one is jet injector. Now we move on to the oral antidiabetic agents. When are the oral antidiabetic drugs indicated? They are indicated in type 2 diabetes, which is maturity onset or adult onset. That's why I'm saying if the age of the patient is more than 35 to 40 years, then the oral antidiabetic drugs can work. They are generally preferred for obese patients, and if the diabetes is of less duration, that's less than 5 years duration. If the postprandial blood sugar level is less than 200 mg/%, then the oral drugs are indicated. Or there's a patient with type 2 diabetes who was on oral antidiabetic drugs, but went into a situation when he needed the insulin by subcutaneous route, and we had placed him on insulin. Now, after the emergency is over, the emergency could be surgery, could be trauma, could be infection. When you put the patient on insulin instead of the oral antidiabetic drug, when this emergency situation is over, then you want to bring back this patient on oral antidiabetic drug. When can you do it? What's the indication? When the insulin requirement falls below 30 units per day, then you can think of bringing the patient back on the oral antidiabetic drugs. Plus, oral drugs are indicated when it is uncomplicated diabetes. So with this, we'll start discussion of the oral antidiabetic drugs. What are they doing? The mechanisms of action can be 2 types. Number 1, stimulate the insulin release from the pancreas. These drugs are called as insulin secretagogues. Insulin secretagogues. They stimulate the insulin release from the pancreas. So they are also called as insulin releasers. Another method of acting of the oral antidiabetic drugs could be to increase the receptor sensitivity of the insulin receptor. And because these drugs are sensitizing the insulin receptor, increasing its sensitivity for insulin, they are called as insulin sensitizers. There are many drugs who can have these 2 mixed actions, but what I told you were the 2 approaches of mechanism of action by the oral antidiabetic drug. Now we can go to the next slide and we can have a view at this nice table. I have written on the top what is the group of oral antidiabetic drug, and below I am describing the oral antidiabetic agents. The first group is called insulin secretagogues or insulin releasers, and in the bracket I write what's the site of action so that you will be sure where these drugs are acting. Insulin secretagogues obviously will act on the pancreas. So they act on the pancreas, and these drugs are used in non-obese diabetic patients. We are talking about sulfonylurea, you can see the cursor, and we are talking about the meglitinides, these 2 drugs. I am saying that these drugs are preferred in non-obese diabetic patients, and we have to find out the reason immediately why I said it. Let's go to the last column and let's have a look at the adverse effect written in red. In front of sulfonylureas, I hope you are following the cursor, important adverse effect is weight gain. In case of Meglitinides, again, an important adverse effect is weight gain. Means when you are going to put this patient on these oral anti-diabetic drugs, the patient is going to have gain in the weight. And this is why these drugs are preferred in non-obese diabetic patients. Next, we go to discussion of sulfonylureas. They are the long-acting drugs. And the second group written on this page, that's Meglitinides. These are short-acting drugs. So in one view, you will be able to differentiate why sulfonylurea and why Meglitinides. Sulfonylureas, same mechanism of action, but they are long-acting. Meglitinides have got a short duration of action. Let's discuss how these drugs act. Sulfonylurea, they block the ATP-sensitive potassium channels, and this inhibits the outward current of the potassium. It's called potassium efflux. So they are going to block the potassium which is going outside. Now because the potassium concentrates inside the cell, it will lead to depolarization, and this depolarization stimulates the entry of calcium, and as soon as the calcium enters, there is release of insulin. So that's the mechanism of action, blocking ATP sensitive potassium channels, inhibiting the efflux of potassium, leading to depolarization, leading to increased calcium entry, that finally leads to increased insulin release. That's the mechanism of action. So coming to the effects of the sulfonylureas, they increase the release of insulin, they decrease the release of glucagon, they help to increase the tissue glucose uptake though, so the tissues will be taking the glucose, then they inhibit the hepatic glucose output so that the glucose is not brought to the systemic circulation by the liver, and they help to increase the receptor number, that's insulin receptor number, as well as the sensitivity of the insulin receptor. So these are various actions which sulfonylurea produce, and Meglitinides produce similar actions, but the difference is they are short acting and the onset of action is more rapid and the action lasts for much shorter time. Sulfonylureas are preferred for day-to-day maintenance, and Meglitinides are used as adjuncts because they have got a short action. They can be just postprandial regulators of glucose. It means you have to take the drug at the beginning of the meal, and it's going to take care of the rise of the blood sugar immediately after the meal. Meglitinides can also be used if the patient has got allergy to sulfonylureas. So these are the indications for Meglitinides. Let's go to discuss the sulfonylurea. They are divided into generation 1, and the newer drugs, those are generation 2. The older sulfonylureas or the generation 1 sulfonylureas are chlorpropamide, tolbutamide and tolazamide. The newer or the second generation sulfonylurea are glyburide, gliclazide, glipizide and glimepiride. I have written gliclazide, glipizide and glimepiride in green color, and only glyburide is written in blue color. This glyburide is the most potent sulfonylurea. And when a drug is most potent, it's likely to produce profound hypoglycemia, because hypoglycemia will be the adverse effect of sulfonylureas. They are the drugs which are going to increase the release of insulin. Naturally, their expected adverse effect will be hypoglycemia. You have Meglitinides, there is repaglinide and nataglinide, and as I said, they are used before meals 3 times a day, every time before the meal. Meglitinides also produce hypoglycemia, they also produce weight gain. So we discussed about the last group. Now we go to the first group, that's the sulfonylurea. Common adverse effect is hypoglycemia. Next one is gain in the weight. On long-term use, they have got the liability to produce hepatic and renal dysfunction. And very importantly, do you remember your alcohol chapter? Chlorpropamide and tolbutamide, they can produce alcohol intolerance. So while the patient is receiving a sulfonylurea, the patient is not supposed to consume alcohol because these drugs have got disulfiram-like effect. The next adverse effect is not very common, is typical for chloropropamide, and that's cholestatic jaundice. Please remember CH chloropropamide, CH cholestatic jaundice. And then we can have various drug interactions of sulfonylureas with the other drugs which are producing hypoglycemia. There will be profound hypoglycemia. So that's about the insulin secretagogues in the form of sulfonylureas and meglitinides. Let's go to the next slide. Yeah. The second slide about oral antidiabetics is about the insulin sensitizers. This is what I had said, that these could be the two approaches. One, increase the release of insulin, and second, increase the sensitivity of the insulin receptors. These drugs are mainly producing sensitization of the insulin receptor, so they are called insulin sensitizers. And when I am speaking, what could be their site of action? Obviously, the site of action is where insulin receptors will be present. And the sites include, important site is liver, and the second important site is all peripheral tissues. So that's insulin sensitizers. They are not producing a prompt release of insulin from the pancreas. They are not insulin releasers. Naturally, they don't produce profound hypoglycemia. They try to normalize the blood sugar. So normalization of the sugar is called euglycemia. And this is why insulin sensitizers are sometimes called euglycemic agents. Which agents we are talking about is biguanides. And there's only one biguanide shown on this slide. That's metformin, used in a dose of a wide dose range, 500 to 3000 milligrams every day, and it should be given 2 times a day or 3 times a day. So that's biguanide, metformin. When to prefer this agent? When to go for sulfonylurea? When to go for biguanide? If you remember the previous slide, we had said sulfonylurea should be preferred for non-obese individuals. What was the reason? Because these drugs lead to weight gain. Now look at the adverse effects of biguanides. It's interesting. I have underlined it. Biguanides produce weight loss. And because they are producing weight loss, these are the ideal agents for the patients who are already obese. So if a patient is obese, he is going to be benefited with the biguanides because biguanides produce weight loss. Let's come to the first column to see the actions. What are the insulin sensitizers doing? They are going to decrease the gluconeogenesis and they are going to decrease the glucose production. How do they act? They activate the AMP activated protein kinase. This is called AMPK, and this is present in the hepatocytes. So it will have the action on the hepatocytes. We said major site of action will be liver. So they activate the AMP activated protein kinase, that's AMPK, in the hepatocytes. In addition, they increase the sensitivity of the insulin receptor, as we already said, and the glucose uptake is increased. Biguanides is metformin. Their adverse effects include anorexia, a sensation that I need not eat now. I don't want to eat. That's a typical sensation. It's not nausea. It's a feeling that I should not eat. A little lack of appetite. And because they have got this adverse effect, the patient slowly eats less, and this leads to weight loss. And this is why these agents are preferred in obese diabetics. Other adverse effects of metformin include metallic taste, abdominal discomfort, and rare lactic acidosis. So biguanides, anorexia and weight loss, metallic taste, abdominal discomfort, and rare lactic acidosis. We move further in the chapter of oral antidiabetic drugs. That's the third slide for oral antidiabetics. We discuss the drugs called thiazolidinediones, and they are also called glitazones because their names end with glitazone. These are the analogs of peroxisome proliferator activated receptor gene gamma receptor. So they are the analogs of PPAR gamma receptor. This PPAR receptor gene is involved in the regulation of the glucose metabolism as well as the lipid metabolism. The actions of thiazolidinediones include decrease in the insulin resistance, increase in the uptake of glucose, and inhibiting the gluconeogenesis. And we have a drug in this group is called pioglitazone, which is used in the dose of 15 to 30 milligrams every day or 2 times a day. And there were many glitazones on the market in past, and slowly they proved to be cardiotoxic, and that's why most of them have a restricted use in certain special situations, or they have been withdrawn from the market. What exists now is pioglitazone, and it also has the liability to produce cardiotoxicity, weight gain, edema, and congestive heart failure, and this fluid retention. So that's about glitazones. The next group is alpha glucosidase inhibitors, and they have got a novel action. They are interfering with the absorption of sugars. The site of action for alpha glucosidase inhibitors is intestine. You know, when you eat something, if there's a complex sugar in your meals, this complex sugar has to get converted into glucose, has to get broken down into a simple sugar, that's glucose. And this job is done by an enzyme, alpha glucosidase. This alpha glucosidase is present in the brush border of the intestine. And these drugs, alpha glucosidase inhibitors, they inhibit the enzyme alpha glucosidase so that the complex sugar is not converted immediately into glucose. So look at the effect. Come to the first column. There will be decreased absorption of glucose. That's the action of alpha glucosidase inhibitor. And once the amount of glucose in the blood itself is less, is going to decrease your insulin requirement, is going to decrease your requirement of the oral anti-diabetic drug. So this is called insulin sparing effect or decreased dose requirement of insulin. The drugs in this group, a very apt name is acarbose and miglitol, and these drugs should be given half an hour before meals so that they'll reach the intestine, the brush border of the intestine, and by the time you take your meal, a complex sugar comes, they are going to restrict, they are going to inhibit the conversion of the complex sugar into glucose. 50 to 100 milligrams 3 times a day or 4 times a day, that's the dose. Their adverse effects include GI discomfort, diarrhea, and flatulence. A special point, salient feature to be remembered about alpha glucosidase inhibitor is, if you get hypoglycemia and if you try to eat the simple table sugar, which is sucrose, the hypoglycemia is not going to get corrected because you ate sucrose and this drug is already present there, which is going to inhibit the conversion of sucrose into glucose, so there will be no supply of glucose to you. So hypoglycemia not corrected by sucrose, that's the specialty of the alpha glucosidase inhibitors. We'll stop at this session, and then on the next session, on another session, we shall continue with more oral anti-diabetic drugs. Thank you so much.